Hypercalcemia. Letter of Referral. Dear Dr. Re. MRS Sally Ann Cook, aged 54 years. This 54-year-old teacher presented with loin pain to an acute urology take and was found on CT scanning to have several left-sided ureteric calculi. These have been managed conservatively, but initial investigation revealed a serum calcium of 2.8 mol/L and an endocrinology opinion was suggested. I would be grateful for your advice regarding further investigation and management. Yours sincerely. Introduction. Most urinary tract calculi contain calcium and most patients, 65%, have idiopathic hypercalciuria, but some 5% have underlying hypercalcemia, as in this case, which ideally should be confirmed on an uncuffed venous sample. Although the differential diagnosis of hypercalcemia is broad, Table 1, the presence of a renal stone usually implies that it is long-standing and therefore unlikely to be secondary to malignancy. The most likely diagnosis here is primary hyperparathyroidism. History of the presenting problem. With increasingly frequent use of biochemical testing, hypercalcemia is often found incidentally or as a result of directed screening, such as in this case. This means that frank symptomatology is uncommon, but symptoms of hypercalcemia should be specifically sought. These usually occur when the serum calcium exceeds 3 mol/L and comprise thirst and polyuria, constipation, anorexia and general malaise, depression and anxiety. More severe hypercalcemia can lead to vomiting, severe dehydration, confusion and even coma. Other relevant history. Careful inquiry should be directed towards possible causes and complications of hypercalcemia. Functional inquiry. A full systematic functional inquiry is needed. Respiratory symptoms might suggest sarcoidosis as the cause of hypercalcemia. Gastrointestinal symptoms might be a consequence of hypercalcemia, but could be causal if leading to excessive consumption of milk or alkali. Any features suggesting malignancy should be explored, especially in patients presenting acutely. Drug history. Ask specifically about lithium. The mechanism of action remains unclear but may involve altered calcium sensing by the parathyroid glands and enhanced effects of parathyroid hormone, PTH. Thiazide diuretics reduce urinary calcium excretion and potentiate the effects of PTH. Vitamin D intake, either oral or topical, for example for psoriasis. Milk, alkali, antacids. A detailed drug history, including use of over-the-counter treatments for indigestion, white medicine, or of vitamin D-containing preparations, is essential in the patient with hypercalcemia. Family history. A family history of hypercalcemia or a personal history of pituitary or pancreatic islet cell tumors may suggest the presence of multiple endocrine neoplasia, men, type 1. Familial hypocalciuric hypercalcemia, FHH, should also be considered in familial cases of hypercalcemia. Complications of hypercalcemia. These include peptic ulceration and acute pancreatitis. Is there a history of bone pain or pathological fracture? If not due to malignancy, these may be caused by long-standing hyperparathyroidism. Ask directly about urinary stones, which were the presenting feature of this case. Plan for investigation and management. First, explain to the patient that under normal circumstances you would perform a full physical examination looking for signs associated with the conditions. Investigation. All patients presenting with hypercalcemia should undergo the following investigations. Routine hematological and biochemical tests, including FBC, inflammatory markers such as erythrocyte sedimentation rate, ESR, and C-reactive protein, CRP, electrolytes, and renal/liver/bone function tests, measurement of serum PTH, chest and abdominal radiographs. Look for the following clues. Anemia may indicate malignancy, including myeloma. ESR, CRP, raised in malignancy, especially multiple myeloma. Impaired renal function, usually a consequence of hypercalcemia, but remember that advanced long-standing chronic renal failure can cause tertiary hyperparathyroidism. Phosphate, low in hyperparathyroidism, raised in multiple myeloma, particularly when accompanied by renal failure. Alkaline phosphatase, bone isoenzyme reflects osteoblast activation. Abnormal liver function tests, consider malignancy. PTH, suppressed in virtually all causes of hypercalcemia except hyperparathyroidism, where a detectable PTH level, normal or high, is inappropriate for the serum calcium level. CXR, look for primary or secondary malignancy, or hilar lymphadenopathy suggestive of sarcoidosis. Abdominal radiograph, kidneys, ureter, and bladder look for urinary tract calcification. Chest radiograph or CT, look for primary or secondary malignancy or hilar lymphadenopathy suggestive of sarcoidosis. Abdominal imaging, ultrasound and/or CT, look for urinary tract calcification, already established in this case. A serum PTH within the normal range is inappropriate in the context of hypercalcemia and suggests that the patient has hyperparathyroidism. Hazard to avoid unnecessary and ineffective surgery. FHH must be excluded in any patient presenting with hypercalcemia and a raised PTH in order to avoid unnecessary parathyroid exploration. Diagnosis depends on demonstrating a low urinary calcium creatinine clearance ratio and can be confirmed by screening for mutations in the calcium sensing receptor, CASR, gene. Key point. Distinction between hypercalcemia with suppressed versus non-suppressed PTH helps guide further management, e.g. the finding of hypercalcemia with a clearly detectable PTH indicates a parathyroid origin and further investigation for occult malignano is not indicated. Key point. Vitamin D status should be determined at diagnosis as vitamin D insufficiency or deficiency may be associated with a raised PTH, in which case consideration should be given to careful replacement which may lead to resolution of hypercalcemia and normalize PTH. However, caution is required as vitamin D therapy in those with underlying primary hyperparathyroidism predisposes to marked hypercalcemia, hence it is important to obtain specialist endocrine advice before implementing this strategy. Other tests will be driven by clinical suspicion and the results of these initial investigations. Serum electrophoresis, urinary testing for Bence-Jones protein, and a skeletal survey, if multiple myeloma is suspected, hence a first-line test in any patient over the age of 50 years with hypercalcemia. Isotope bone scan for bony metastases. Vitamin D levels may be helpful if intoxication is suspected, but require careful interpretation given their wide seasonal variation. Urinary catecholamines, thyroid function tests and synacthin test. 24-hour urinary calcium excretion, low in FHH. In this case primary hyperparathyroidism is the most likely diagnosis, and after normal or high PTH is confirmed in the presence of hypercalcemia, investigation should be directed towards assessing complications and, depending on local practice, identification of the overactive gland, S. Management. Hypercalcemia associated with complications. Specific treatment will depend on the underlying disorder. In this case, given the history of urolithiasis and assuming the diagnosis of primary hyperparathyroidism, definitive treatment should be offered. For a solitary parathyroid adenoma, the preferred option is surgical excision. The only controversy is whether preoperative imaging should be performed, for example with 99 mTC sestamibi scanning and/or neck ultrasound. Currently this depends on local practice and expertise. Postoperatively transient hypocalcemia may occur, which can be treated with intravenous 10% calcium gluconate in the acute setting, or with a combination of oral vitamin D and calcium supplements in milder cases. Asymptomatic hypercalcemia. With a diagnosis of primary hyperparathyroidism, a calcium level that is only mildly elevated, e.g. 2.8 mol/L as in this case, in the absence of symptoms of polyuria and polydipsia or confusion, and with no evidence of urinary tract calcification, it is debatable whether any immediate specific treatment is required based on the biochemistry alone, other than ensuring adequate hydration. It would be appropriate to give the patient advice to drink around 3 L of fluid daily and monitor the serum calcium and PTH every 6 to 12 months, sooner if symptoms develop. Further discussion. Surgery for asymptomatic primary hyperparathyroidism. In recent years practice has changed, and it is now more common to offer early parathyroidectomy, especially as expertise in minimally invasive day case surgery grows, rather than waiting for hypercalcemia to become more marked or complications to develop. In the absence of symptoms or clinically overt complications, guidelines have been developed regarding which patients should be offered surgery based on evidence of hypercalciuria and bone mineral density loss. Familial cases of hypercalcemia and hyperparathyroidism. If associated with suspected or confirmed MEN1, then it is important to counsel the patient that hyperplasia of all 4 glands generally requires total parathyroidectomy. FHH is typically associated with a family history of mild hypercalcemia. Screening using the urine calcium/creatinine ratio is mandatory if inappropriate parathyroidectomy is to be avoided.